welcome to today's discussion for Diabetes Eye Disease Awareness Month on the theme Understanding the Growing Burden and Latest Advances in Treating Diabetes Related Vision Loss, presented by Roche and hosted by ET Healthworld. Today, we are addressing the urgent issue of diabetes related vision loss and the latest treatment advances. As diabetes heightens the risk of irreversible vision impairment, immediate attention is critical to address this often overlooked health challenge. Join us as we engage with experts to explore solutions for bridging healthcare gaps and preserving sight for millions. I am Pratibha Raju, Senior Assistant Editor from ET Health World, and I'll be moderating the session. And for today's discussion, I must say we have a very well-rounded panel of experts. We have Dr. Phanindra Babu, CEO at Vision 2020 Right to Sight India. Thanks a lot, Dr. Phanindra, for taking out time and joining us for this important topic. And next, we have Dr. Vishali Gupta, Vice President, Vitero Retinal Society of India, VRSI, and Senior Consultant Professor, Head of Retina, UVA Services at Advanced Eye Center, PGI, Chandigarh. Thanks a lot, Dr. Gupta, for joining and making your time for this important discussion. And we have Dr. Manoj Chavla, diabetologist, executive member, Research Society for the Study of Diabetes in India, RSSDI. Thanks a lot to all the panelists who have joined us today. And we've also have Dr. Rohit Khanna, Regional Chair, International Agency for Prevention of Blindness, Southeast Asia, with us. Thanks a lot, Dr. Khanna, for for joining in for the discussion. So let me start with the discussion, and I have this first question. There is negligible awareness about the fact that uncontrolled diabetes can adversely impact one's vision health. Why is this case? So, could you all explain how diabetes specifically affect the eyes? I would like to go to Dr. Rohit.
Thanks Roche and ET for organizing this webinar. I think it's very important. This is the Diabetes Week also, Awareness Week also. So diabetes as such doesn't only affect eye but multiple organs, but eye is one of the major organ which is very important sensory organ. And usually diabetes changes usually starts much later than the onset of diabetes, but most of the time we pick up people in late stages. So what diabetes starts is doing is initially microvascular changes. It not only happens in the eyes, but also in the other parts of the body, in the other blood vessels in the body. So slowly there are leakage from this microvascular changes, because of which there are leakage of proteins and all. And leads slowly, it's basically vascular changes which are happening across the body, and what vessels formation, hemorrhages, exudate formation, then slowly goes to edema, and then goes to advanced stage of diabetic retinopathy. There are different stages like mild, moderate, severe, and proliferative. 4 stages of diabetic retinopathy, and then there are with macular edema and without macular edema. Macular edema is a place where macula is a place where you see the vision. What you see long distance vision 6/6, and so you see a long distance vision. It's through the macula. What you see people around you is basically most of the time you use your macular vision, and peripheral visions are used for other things, but most commonly used is macular vision. And movement, the vision drops where you have swelling or fluid collection in the macular area. Probably at that time many of the patients present to us, and sometimes they are picked up by chance. But what's happening is like what is needed is like anybody above 40 years should go for regular screening. So basically this is how slowly diabetes leads to vision loss. Initial changes are reversible when you have microaneurysms, small hemorrhages, but over a period of time, if you don't do it, probably it starts going into the worst stage of retinopathy and sometimes leads to blindness and all. And also there is high risk of these people developing cataract, other problems like dry eye. Okay, so these are major issues which happens with the diabetic patients.
Thanks a lot.
Dr. Vaishali Gupta can add, but I'm not a retina
Yeah.
specialist. I'm more of a
I
glaucoma,
know.
so I'm just
Sure.
pitching in on behalf of Vaishali, but if Dr. Vaishali Gupta can brief more about it, what I have said upon.
Thanks a lot for those
Yeah.
initial comments. Dr. Vaishali, over to you. If you can just let us know, there is negligible awareness about the fact that uncontrolled diabetes can adversely impact one's vision health. So maybe a lot of inputs from your side, so the patients who are listening to us will benefit out of it. Over to you.
Once a patient is a diabetic, more than 90% of them will have their retina affected at some point of time. So, as the duration of diabetes keeps on increasing, there is more and more chance that your retina will be affected. And what we have to remember is that when the retina gets affected, the earliest sign, there are two ways the retina gets affected. One, there is accumulation of fluid in the center, as Dr. Khanna pointed out, which we call edema, macular edema. So the earliest problem the patient will experience is difficulty in doing near vision. So they get the glasses checked, but the near vision is not improved. So that might be one of the very early signs that your retina is getting affected. The second changes that diabetes causes in the eye is that there are abnormal vessels which form in the eye, and that is more serious a problem than the leakage. So what happens? These abnormal vessels, when they form, they bleed because they are not normal. So they tend to bleed, which causes total loss of vision. And if the bleeds keep on happening, then the retina gets detached and eventually blind. Most important thing to know is that when these vessels start forming, patient will not have any complaints in the vision because these vessels form on the sides of the retina, and till the time they bleed, patient may be totally normal. So the very important message is that if we treat the vessels when the vision is normal, we are able to keep it at that point. But if the disease becomes advanced, like Dr. Khanna says, and the patient comes to us at a late stage, we are not able to reverse the damage or the vision. So for that point of view, it's very important that we have regular screening. Even if they do not have any complaints, they should make sure that retina person is examining their retina once a year to detect any of these new vessels developing.
Thanks a lot, Dr. Vaishali. Mostly, it's like prevention is what is being told here.
Yeah, there
Yeah,
are two things.
yeah.
One is the prevention. Prevention means that if you keep diabetes under control, you can actually delay the onset of changes in the retina. And the second is detection. Even if they have developed, you should be able to detect it very early.
Okay, so let me go to the next question, and this is also again a straight question. We wanted to understand the basics also. So, what is diabetic retinopathy and diabetic macular edema? How do these conditions affect eyesight, and what kind of challenges do patients suffering from both, like DR and DME, face? And what is a socio? Let me come to the socio-economic impact later. I just want to know, in simple terms, like what is diabetic retinopathy and DME and how it affects. So let me go back to,
Picking,
Dr.
but
Vaishali. Yeah, if you can go ahead,
Yeah.
please.
As I mentioned already, diabetes causes two type of changes. The first type is the blood vessels, because of the high blood sugar level, they start leaking. So normally when we have blood vessels in the retina, they are very tight. They do not leak. But in diabetes, they start leaking. So when they start leaking, the fluid comes out of the blood vessels and it starts getting collected in the retina. Now, what is retina? Retina is like a film in the camera. For those of our patients who would have seen the cameras, the old time cameras, we used to have a roll, a film. So film is like retina where the image is formed. Now you imagine if the film of the camera was hazy. So even if you have everything, the light coming there, you will not get a good quality picture. So when there is fluid in the retina, which collects in the center, we call the macula, which is the center of the eye. So now there is fluid, and even if the light is focusing there, it will be blurred, and the patient will complain of difficulty in reading, mostly doing the near work. They will not go blind because of the leakage. It will just affect their near work. That is one part of the story. The second part of the story is that when diabetes affected, the blood vessels, they start getting closed. Instead of leaking, they just get closed. So when blood vessels are getting, we call it occlusion. When they get occluded, because the oxygen supply gets reduced in diabetics. So what happens? The body tries to compensate. Now, retina is not getting oxygen. Retina wants more oxygen. It starts forming abnormal vessels. Now, those vessels are not normal. They are abnormal. They are fragile, and they just break down and start bleeding in the eye. So once that happens, patient will complain of floaters. They will say there is a black thing floating because there is now blood in the eye. If that blood is not taken care of, then it keeps on happening again and again, and it causes a pull on the retina, and the retina is not in its place anymore. It gets detached. It gets very complicated, and the vision falls down a lot. At that point of time, we can only do surgery because there is no alternative. So to important point, which I said earlier also, that in the very early stages, when these abnormal vessels are just forming, patient may have normal vision, but if a retina specialist is able to detect it, laser them, do the treatment, we can preserve the vision. If, however, patients are not knowledgeable about routine screening, so automatically, like even I would do that, I will go to the doctor only if I have complaints. So they will go to the retina surgeon only once they have a bleeding, which already means we have gone to a later stage of the disease. So that is the importance of early detection and awareness.
So, what is the socio-economic impact, you think, of these sight-threatening conditions, Dr. Vaishali?
The socio-economic is one is we are going to be 300 million diabetics by 2030 in India. The second part is diabetes affects the productive age group. It's not a disease of the geriatric population. It's a disease which starts around 30, 35 years, and it affects your career and your work while you are at the peak of, and you are in the productive age group. You might be the only earning member of the family. So once you're due to the edema, near vision is affected, patients find it difficult to work on the computer, to do the near work, but they may be able to do work of supervision. Say somebody is a contractor, or they may still be able to do. However, when the new vessels form and they bleed and they cause the sequelae of this, patients are not able to see at all, both distance and near. So that affects their overall career because they are just not able to work. And we also have to understand, Dr. Khanna said it very beautifully in the beginning, that when changes are happening in the retina, it is just that in retina we can see, but 90% of the time, those changes are also happening in the kidneys, in the heart, in the other blood vessels. So overall, the health of the patient is deteriorating. They're not able to work, and the disease involves both eyes. That is also the unfortunate part, that it's not only one eye, both the eyes would be affected. So it affects your earning. It has a huge burden as far as the treatment is concerned because it requires Regular injections in the eye, lasers, surgery, they're expensive things, so there is a burden. And these are the patients who do not get care at their doorstep. Many of these specialized treatment, they will have to go a certain distance to reach the retina specialist, which involves traveling. And since they are not independent anymore because of the visual disability, they would also need an attendant or sometimes even two, three attendants accompanying the patients. So all this adds on. And if God forbid they also develop kidney disease and heart disease, then they go to eye doctor, kidney doctor. So it impacts the entire social framework of the family, not only the patient.
Thanks a lot, Dr. Vaishali. I would quickly go to Dr. Manoj here. Being a diabetologist, you might be like also associated with such a big association. So you might have inputs on DR and DME and how these, like, if you don't want to go to the technicalities, like medically, but you can, if you can touch upon the socio-economic impact of these sight-threatening conditions, if you want to add on few pointers. Dr. Manoj, over to you.
Sure, Pratibha. So I think very valid points have been mentioned about this condition, which continues to be one of the known microvascular complications of diabetes. Well, you did start with asking in terms of the awareness being poor about the diabetic retinal disease, whether it's retinopathy or macular edema, and that continues to be true. Unlike the other complications that people may be more aware of, you'll have individuals with diabetes asking aspects about diabetic foot gangrene or even the kidney damage is more known. Somehow, though retinopathy, as Dr. Vishali said, is extremely high prevalence and almost 90% will end up with some amount of retina affection in their course of diabetic lifetime, the awareness about it continues to be poor. Also, diabetes continues to be a silent disease and unfortunately referred to as a silent killer because very often it would not produce symptoms. So many individuals with retinal affection will still not have their vision affected, unless it really comes on to the macular part of it, which will bring about black spots or blackish spots or some blurred vision. A lot of individuals will just not know about affection of the retina. And which is why it is said today that the screening for retinal affection should be done in patients with type 2 diabetes right at the diagnosis. Because very often an individual with type 2 diabetes may have gone undiagnosed for a lot of period of time. And it's not unusual for us, unfortunately, to come across an individual who's newly detected with type 2 diabetes, and we are screening them for all aspects of complications, and we find already the retina to be affected with advanced retinopathy. So, and all of this, of course, with poor vision, affection of vision, may hamper in their day-to-day activities, of course, leading to severe impact on the socio-economic aspect, be its productivity or the cost of care involved around the handling of the complication.
Thanks a lot, Dr. Manoj. Thanks to Dr. Fanendra who's been listening to us since the beginning. So I'm going to Dr. Fanendra next. So as all the other speakers have said, it is a retinal health is need to be looked into. It is a silent killer. So despite the growing concern about retinal health in India, there are still barriers in the ecosystem, policy gaps, awareness challenges, and lapses in treatment adherence. So this has been there and we all know it. So can you shed more light on these issues and like you can let us know what kind of steps can be taken? Dr. Fanendra, over to you.
So this is a very important discussion we're having today, and the good questions, useful for the policy discussion later on also. Thank you for this. So Pratibha, basically the awareness point of view for not just for eye health, generally for any healthcare issue in our country, awareness is lacking. For example, the TB control program or pulse polio program was actually lacking some few years ago. But given the kind of effort that are taken by Government of India, Ministry of Health and Family Welfare, for raising the awareness TB control program or for the polio program. Now today, the TB control program, awareness program have really improved case detection rates in the country. And also today polio is India is now our country is polio free, given the lot of the mega campaigning effect had been taking place across the country, addressing the mass media through the public awareness. So, and also reaching every corner, those kind of campaigns have reached every corner, and also service delivery was made stronger by the government of India. So today we are able to declare India free, polio free. So similarly, I think in eye health also we need such kind of a mega campaigning for addressing the eye health aspects. Mega campaigning. I'm talking about just mega event. The word I'm actually highlighting it, and not just one episode, but just not just 1 week or 3 days or 5 days. Not like it has to be continuous process. Maybe one can take some breaks about it. That's fine. But then overall, it has to be a continuous process of raising the awareness of public population. That is the key of it, and we have received the results in terms of, as I just mentioned, about TB or HIV or the polio programs. So that's one very, very important aspect. And the other aspect, which I think just already touched by Dr. Vaishali, Dr. Rohit, and Dr. Manoj, is that the diabetic prevalence so far in India was, I think, from different studies. Particularly, I'm quoting a study from Dr. RP Center of AIMS, commissioned by the Government of India. Diabetes prevalence in the country is 11.8%, close to 12%. The DR prevalence is 16.9%, again close to 17%. And interestingly, there are no male and female differences in terms of DR prevalence is concerned. While there are differences between in terms of diabetes prevalence between male and female, where male prevalence is higher than the female prevalence of diabetes, but not so in terms of diabetic retinopathy. So I think we need to really understand why it is so, the phenomenon is so different in terms of diabetes versus diabetic retinopathy prevalences between male and female. And also site-threatening DR is 3.6%, again from the same study that I'm quoting it. And also the study quoted that DR is responsible for 1.06% of the blindness. So there the statistics we have it. So generally we need statistics, Pratibha, to address any public health problem. Fortunately, in India, for our country, we have the latest statistics, the 2020 statistics I'm actually quoting about. So fortunately, we have those statistics as a result of Government of India's efforts. And also the challenge is less than 10% of ophthalmologists in India are trained in the management of DR. So probably that's also kind of causing the reaching out the population coupled with the lack of awareness among the early population. But yes, definitely the point that I'm bringing is the raising the public awareness through mass media and continuous process of year-long process of raising the awareness, as we did in the Ministry of Health, Family Welfare, Government of India, the TB and the polio programs. So that's, I think, a key message that I would like to bring in.
Thanks a lot, Dr. Fanendra. Important statistics there. And yes, Dr. Rohit, you have been raising your hand. Yeah, please go ahead.
Oh, no, sorry. It was following the Dr. Vaishali Gupta's comment was like, they're not only like financial implications, but also they have psychosocial implications. They go into depression, their visual function, quality of life, everything is hampered. So it's not only like one factor which is affected. It starts affecting other systemic conditions, other parts of their life also. And plus, apart from that, one thing which I think which didn't come out, and I just wanted to bring it up, like they have sometimes uncontrolled hypertension, which is very, very critical. I think most of the time these two diseases, hypertension and diabetes, go hand to hand, and controlling of their blood pressure is equally important as controlling of their diabetes. And other thing is like looking at, it's a part of like NCD group. The NCD group is like working, the WHO NCD group is there, which is looking at this diabetes, hypertension, chronic diseases, and probably it's component of that. So raising awareness of what Fanindra was saying is just not only about diabetes, but also hypertension and other NCDs also. So we should look at the disease as a whole and try to take care of other pathologies which are associated with this condition also.
Thanks a lot, Dr. Rohit. Let me go to the next upcoming question, because Dr. Fanindra had brought in that mega campaigning is needed. So I would like to ask Dr. Vaishali, how can regular screening and I mean, like you had touched upon this, but still I would want to emphasize, if you can emphasize, how can regular screening and early diagnosis help in managing DR and DME? Are there any examples of best practices or successful experiences you have been seeing regarding regular screening and timely diagnosis? Maybe such campaigns had happened in, like, far-flung areas, maybe, or even in urban areas, which you have seen and you have captured something earlier also. So that would be really a learning for all of us here. Yeah, Dr. Vaishali.
There are two aspects to your question. The first is, have there been any campaigns regarding the awareness about diabetic retinopathy? So two of our major societies, Vitreoretina Society of India and our All India Ophthalmological Society, is working, actually trying very hard along with the Diabetes Association of India. The first thing is the awareness amongst our medical fraternity, because it was very nicely pointed out by Dr. Chawla that diabetic retinopathy is somehow not as, is not as, I don't want to say the word popular, but people are not that much aware about diabetic retinopathy as they are about atherosclerosis and other problems. So they don't routinely automatically send it to a diabetic retina screening. So first thing is to raise the awareness. Vitreoretina Society, we have the advertisement coming up on FM, and we have also collaborated with Tata 1mg, where on the that envelope where they dispense the medicines, they are putting that please get your retina screened. But I don't think that itself is enough. We definitely need more. Now, coming to the second part of your question, that, well, you raise the awareness, but who's going to screen? As per now, we have a population, you know how much population we have, the diabetic, and we have 1,500 retina surgeons in the country. So you don't expect they'll be able to screen that huge load of population, because they just look at the advanced disease and do surgeries. So AI has been playing a very important role, because we do have fundus cameras, which are AI inbuilt, and patient just screens, and you are able to get the report that there is retinopathy or no retinopathy. And we at PGI are working along with Niti Aayog. We are one of their pilot projects where we have put up such cameras in the peripheral areas of Punjab. We have trained the ASHA workers and other government nurses to take the photograph, and we are trying to encourage it, but it's just the beginning. And in the government sector, we still do not have a very well-oiled mechanism for getting the screen. So we need to raise the awareness as well as have the logistics of screening them. Both are equally important.
Thanks a lot, Dr. Vaishali. I'll go to Dr. Manoj and then I'll come to Dr. Rohit. Dr. Manoj, very important question here. I think you must have seen such successful experiences. If you can share it with us, yeah.
So, as mentioned, well, essentially, I think the load of the burden is on the diabetologists, the physicians, and endocrinologists to make sure that their patients are screened. By the time the patient will land up, go and see a vitreoretinal surgeon, it's usually way too late. And actually the burden of screening, or rather the responsibility of screening, lies on us physicians whom the patients of diabetes are seeing routinely. Now, when we talk about screening for complications, there's a standard protocol about which all complications we should be screening for on a yearly basis, whether it is the early screening for nephropathy, or looking for cardiac aspect, or a foot examination, and so on. Now, what would happen in the past is, though there was a clear protocol and we would keep mentioning to our patients, and we would have it on our letterheads and files about instructions and need for regular screening, and please go to your eye doctor and get your retina checked, patients would often be lazy about it or sit onto it and not go. So one practice which has made a huge change in changing this scenario is the availability of point of care non-mydriatic fundus cameras. Now, these are portable fundus cameras, which are now available at most diabetes clinics and diabetes OPDs in the hospitals. Is it the best way to screen? Probably not. I mean, an ideal way would still be by dilating the individual's eye and then getting a picture. But the current technology with the non-dilated fundus cameras, which do good fundus photography, has been a reasonable means of doing it within a few minutes at the doctor's clinic, so that you're not waiting for the patient to go and see the eye doctor, which seldom happened in the past. And this is providing a good means of at least screening and picking up an eye with a problem, which can then be referred to the retinal surgeon to do the needful, or for doing further diagnostics, be it a test called OCT or evaluation further, and then guidance. So this is one aspect which we saw has changed and at least allowed in practices like ours to pick up patients with early signs of retinopathy and refer them to the retinal specialist to do the needful. Today, the other practice that we've seen which has been successful is, again, the use of similar cameras enabled with artificial intelligence generating the report. So AI today has been validated at multiple AI-based algorithms available. We have done that as community camps using mobile vans with the portable devices into the slums and other areas. We've done that in Mumbai. We've collaborated and done that in outskirts of Kolkata, and seen that that's again been a hugely successful means of screening within the community, where you're taking the images and then artificial intelligence is giving the reports, which of course can then be validated and verified by the retinal surgeons, or at least it brings about a screening procedure, and then we are able to refer to the retina specialists. And as we heard, the number of retina specialists or trained doctors is still limited in the country. So we want to take that burden off, screen at the physician's, diabetologist, endocrinologist level, so that only those who require the specialized care can then be referred to the retinal surgeons to do the needful ahead.
Thanks a lot, Dr. Manoj. You had given an elaborate answer. Dr. Rohit, your thoughts on the same, please.
Yeah. So I think I'll just add to what Dr. Vaishali Gupta and Dr. Manoj Chawla has added. Detection, there are two components. What they already alluded upon is awareness creation and early detection. Awareness creation is very, very important among the physicians and also among the ophthalmologists, because many of the ophthalmologists may not examine the retina because they see there is a lens in front of the eye and they will just go ahead with cataract surgery. So many times they miss upon the diabetic retinopathy, or there is something which is happening, glaucoma, which also is associated sometimes the same age group. So there are age-related conditions which are seen in this patient, not only diabetic retinopathy, but they have other conditions. Sometimes they may have glaucoma, they may have macular degeneration. There are so many other conditions which can happen in this patient. So the comprehensive examination of eye is very, very important. And second thing is, like, we need to look at a diabetic care model, not diabetic retinopathy, but diabetic care model. At primary level, what do we do? At secondary level, what do we do? And at tertiary level, what do you do? Primary level, who are your key players? How do you pick up diabetes as early as possible? How do you screen them? How do you create awareness at primary level? More prevention and promotion will come at primary level. Secondary would be more of follow-up care and all, and tertiary will be more of like what Dr. Vaishali Gupta was pointing out. We have very few retina specialists. Many of them need not even go to retina specialists because they will not have any treatable lesion. So they will have some kind of retinopathy, but a regular follow-up by a ophthalmologist at secondary care can take care of many of these diabetes patients at secondary level itself. Unless they see their changes are worsening, they may require a retina specialist. And with the new cameras which have come up with artificial intelligence, I think equipping them at the physician center, at the primary health center, I think it's already started, and I think in long run it will play a major role to pick up these chronic eye conditions, not only diabetes but also glaucoma, macular degeneration, other eye conditions, so that they can be taken care as soon as possible when they are suspected of these conditions.
Thanks a lot, Dr. Rohit. Yeah, Dr. Fanandra, I was about to come to you because I wanted to know what kind of best practices or successful experience you must have also seen. And everybody, I mean, like other three experts have spoken about artificial intelligence here. If you can, stick on to, I mean, like I asked the experts to stick on to DR and DME mostly in retinal health because awareness more is needed in that. So if we can stick on that. Yeah, Dr. Fanandra, your pointers, please.
Yeah, no, I just want to touch upon the points already that Manoj and Dr. Rohit just mentioned the physicians. We constantly talking about physicians. I think so. Generally speaking, usually in our country, the first point of contact in rural areas for a person found to be diabetic, just found to be diabetic, is the RMP. RMP, I'm not here referring to a registered medical practitioner, but I'm referring to a rural medical practitioner who sometimes is unqualified, from the medicine practice point of view. So for that person, I'm referring to as rural medical practitioner. So rural areas, RMP is the first point of contact. And in urban areas, definitely physician is the first point of contact. So they are the ones actually, the any person want to be diabetic, go to physician first, and also in the rural areas, it is actually the RMP. So unfortunately, I mean, at least to my knowledge and my experience, the referrals from the physicians to the ophthalmologist, all from RMP to the ophthalmologist, are very, very less. That is where I think the bottleneck is in terms of early diagnosis of DR. They know that Vaishal is talking about, and what happens if we don't diagnose them early is actually the key also lies here. So the key referrals from the physician to the ophthalmologist and also the RMP to the ophthalmologist are not happening as is expected. So that's what I think one of the important points. Therefore, there is a need to really reach out this segment, both urban and rural areas, and sensitize them about the referrals, to the ophthalmologist, qualified ophthalmologist. So that's one aspect.
Yeah. The next, you have more
Yeah,
to
please,
add?
please go ahead.
No, I was saying that I had hinted about this retina health, and I want the next question would be like India's policy and national programs are more focused on cataracts and glaucoma. We are not saying cataracts and glaucoma should not be the focus, but why do you think the retina and posterior part of the eye have been neglected in these issues, or why it is so crucial and important? Because every other expert here was talking about it, and they were saying like retina health is important and we need a mega campaign. So I would like to start with Dr. Fanindra, if you can go first on this, please.
Yeah, I think from policy point of view, it is not neglected as such. Okay, the policy is very clearly identifies and recognizes the importance of DR in the overall prevalence of overall blindness efforts and control effort, prevention efforts. So policy is very, very clear. And therefore, the National Control Blindness Program and Visual Impairment very clearly recognizes DR as a major one of the major sight-threatening diseases in the country, along with refractive error or cataract or any other glaucoma, any other aspect of eye care. So policy is very, very clear from that point of view. I think probably sometime back a few years ago, we had a consultation, and that consultation recommended setting up a DR task force at the national program. And there was a DR task force set up. We actually will look at these kind of aspects of it, what we just discussing about it. So hopefully that the task force meeting and coming up with various recommendations, but we had to really see kind of progress that task force is making. But yes, policy point of view is very, very clear. So I think the issue is from the quantitative point of view, look at the blindness is mostly because of untreated cataract, which is 66%. The cataract, accounts for 66% of the blindness in the country, followed by other conditions. Post-operative complications, 7.2%, followed by DR, etc., etc. So in terms of quantitative statistics, it actually, giving the low importance. That's how the statistics talk about. So, but the policy actually is equally treating every element from the government point of view, is really equally treated, and policy is very clear about it. So probably I think policy implementation is what something I think one can look at it at the state level. Probably, as we mentioned about, only 7 to 8% or less than 10% of ophthalmologists in India are trained in the management of DR, particularly because we talk about DR and DME. So that could be maybe a reason. And also the kind of supplies issues, the kind of the medical equipment issues, injections issues which are there in the supply chain. Those are the operational aspects what one has to look into it.
Yeah, Dr. Rohit, since you're dealing with glaucoma majorly, so I think you can, give a detailed answer. Over to you.
No, so what Fanindra was saying was basically cataract is a problem there, but what happens in these studies is like easily treatable conditions are labeled as like if you have a cataract and diabetic retinopathy, you will pick up cataract as a cause of visual impairment because it's easily treatable. Diabetic retinopathy is not easily treatable, so they will not label. So it will be always underdiagnosed in these population-based studies unless the study is focusing specifically on diabetes and diabetic retinopathy. Then only you will pick up the prevalence, and that's what the national studies showed. Different states, there was a pan-India study which showed the prevalence of diabetes and diabetic retinopathy in this population, and so that's one thing. So and of course, many of these patients will come with cataract and they need to get cataract surgery done also. Cataract also onset is much earlier in these patients. So when they come, they will have cataract, and when you remove the cataract, you will see a florid retinopathy sometimes behind the eye, which is causing the loss of vision for these patients. So uh, we should not only screen them for only diabetes, but if you are not able to screen from diabetes, you see cataract, you always tell them to go and get cataract surgery done. You don't know what's hidden behind the eye. It can be a glaucoma, it can be macular degeneration, it can be any other thing, any other pathology. It can be a tumor also, ocular tumor. Retina is such a structure which can have, you can pick up so many conditions in the body. Probably, I think that is something, even if they have a cataract, we should encourage them to go and get cataract surgery done so that they can pick up these conditions much earlier. And probably, when you go for screening, it's not only diabetes. I think we should combine it with other NCD screening because otherwise it doesn't become very cost effective. You can screen for other conditions like hypertension, you can screen for cardiovascular diseases and so on. So probably I think that will pick up many more conditions. You will, and probably better use of the resources because everybody is pushing everything to ASHA. So moment everything comes primary level, let's give it to ASHA. So how much ASHA can do actually, like, so how you're going to moment you say government of India, anything is like ASHA workers, give it to primary level ASHA. But how do we engage other key players? It's not a very rocket science to pick up these things. So is it ASHA only? Like Fanindra was saying, you should include RMPs. You should include other health, allied health professionals, especially the Ayush workers, Ayush healthcare practitioners, because they should get involved in this. Because many of the patients believe in them actually. They will not, it's not like you are a topmost physician, you go to the village, people will come to you. They go to the family physician business is still very rampant in the villages, in the communities. So they trust that physician. So probably getting them involved in our program, I think, is the way to go rather than we going and running a vertical program and they running their own program. It will just it will not reach where we want to reach. We'll reach somewhere, but not to the end point, where we want to reach.
So I was coming to Ayushman Bharat scheme, but I would like to ask Dr. Manoj, you have any pointers for this, or should I just go to the next question on which would be specifically on Ayushman Bharat scheme? Anything which you would want to,
No, I
you
think
know?
a lot of points have been covered, so we can move ahead on the
Yeah.
discussion. Right.
Okay. So my next question is, how can the National Program for Control of Visual Impairment strengthen its focus on retinal condition? Do you think retinal health should be included in the Ayushman Bharat scheme to improve access to care and prevent diabetes-induced blindness? I think this is a very important question. Maybe a lot of them were wanting to ask. So I would go to Dr. Manoj first on this.
Right. So when we talk about national policies and the programs which are conducted, I think all of us have highlighted here the need for having a will to create awareness and to execute that. So when it comes under any of these national schemes, the implementation at the grassroots level is going to be obviously better. Dr. Faninder and others did point out about clearly a far better awareness when it comes to cataracts and glaucoma and prevention of blindness through those efforts. The retinal disease largely tends to be ignored in that sense, and people are less aware. So when we start talking about it and we have campaigns about creating awareness, and then of course when we have it under the national programs and the Ayushman Bharat and various such national schemes, of course the reach is going to be much better through these programs, and hopefully the implementation of early screening and treatment offered at an earlier level will lead to prevention of blindness and complications due to advanced retinopathy. And that's something that we are hoping to see with changes in the policies and more implementation of these programs.
Yes, Dr. Fanandra, your point
Yeah,
is.
I think Pratibha, see, the Ayushman Bharat scheme actually included the retinal disorders in its portfolio, like any other eye health condition. So largely they included integrated. But I understand from a last discussion sometime back, we're also having a discussion, some another panel discussion we were talking about. There are certain elements of it which are not included in the Ayushman Bharat scheme. I think certain types of injections, also something like that, which are peculiar to the client specific needs. So those specific injections or certain secondary treatments which are required, very much required for certain segment, they are not included in the Ayushman Bharat scheme. So I think that's it. One is to really look at that. What are specific those injections which are really required to be included in the Ayushman Bharat scheme? What are the secondary treatment procedures which are not part of the Ayushman Bharat scheme is what one has to really list out and really talk to Niti Aayog. But prima facie, by and large, the retinal disorders are all part of the scheme.
Okay, so there is few something is being covered by the Ayushman Bharat. Okay, Dr. Rohit, yes.
Nothing. I think again I will just point the same thing where we should use the advocacy. A lot of advocacy is required with the government of India, and I think it's not only ophthalmologists. Probably it should go together with the NCD group. I think we have worked with the NCD group, and probably I think things move much faster because when you talk about NCD, which include diabetes, hypertension, cancers, lung diseases, chronic respiratory disease, which are big problems in the country, and slowly they are increasing only. So if you go along with the physicians, along with the NCD group, probably I think the advocacy becomes much stronger than just going with the ophthalmologist to the Niti Aayog or Ayushman. We can always go with the same ophthalmologist also, but probably involving these people also because they may have their own things. So, and government of India also is pressed with like multiple health interventions. So they have to make a judgment like which all things which should include. They have to prioritize. Okay, this is more important than this, and this is more important than this. So probably we should include this and not this. So unless that advocacy happens at the national level, probably at the global level, I think things will move very slow.
Okay, an holistic approach is needed at the global level, is what being stated. So, I think there are a lot of questions which is being asked by our viewers here, and our I should say our doctors are so experts. They have been giving the answers there right away. So, I would like to go on to the next question, and I would like to take this to Dr. Vaishali. Given the delayed diagnosis of diabetic retinal diseases, that's what we have been seeing. Do you often see patients presenting their condition at an advanced stage, mostly coming to you only at an advanced stage? And what vision gains and patient benefits can we expect from newer advancement treatment options like faricimab? It's one of it. Like if you can touch upon it, more such things like this.
I see most of them at a very advanced stage, being a tertiary care referral institute. And faricimab is not for the advanced visual loss. Faricimab is for the moderate visual loss, which is mostly due to diabetic macular edema. So most of these injection work when there is a leakage in the center of the eye, which is not truly blinding, though it does incapacitate you in terms of your reading abilities. When the disease gets very advanced, there is a lot of bleeding. There is, at that particular time, most of the time, what they require is what we call vitrectomy, which is the surgeries. We clear the blood, we fix up the retina. It's an expensive business because you need to spend money just to buy the consumables. Even in our institute, there are no charges for the services, but they have to pay for the consumables. Ayushman Bharat takes care of some of the problems, but not all the aspects are covered by Ayushman Bharat. And how much vision they will recover will depend. If they come in a very advanced stage where the retina is already detached and you do a complicated 3-hour surgery, you may be able to fix the retina, but still the vision does not come back because their blood vessels are all, occluded. There is no blood supply. So it's most of the time, the rough algorithm is that 60% of the time, we will be able to keep the vision where it is. Like if the patient comes to me with better vision, I will be able to preserve it. If the patient comes to me with a very poor vision, I will be able to preserve it. 20% of the time after surgery, there may be even further deterioration, and 20% will be improvement. So it's overall 80% where you will have either improvement or stabilization, and that too mostly stabilization. So that is why it's important to visit the doctor when your vision is still better, because at best we can achieve stabilization.
Thanks a lot, Dr. Vaishali. I would like to go to Dr. Fanindra. I will come to all three of you. This question is, what needs to done to prioritize retinal health in India to address its growing burden? Though we had covered bits and pieces of it, if you can just summarize and tell us. And how can retinologists and diabetologists collaborate to raise awareness and promote screening, early diagnosis, and treatment for DR and DME? Dr. Fanindra.
So one is definitely the answer lies in the coordination and collaboration, Pratibhaji. So as Dr. Rohit also mentioned, it's basically all of us work together with NCD groups or with some other physician groups, etc. All of us have to join hands together and work on this issue because it requires that kind of collaboration, coordination. And the other one is we have different occasions like Wall Side Day, or the whole November month for Diabetes Month, etc. They are the special occasion that we have it. We need to really take them seriously and do the community screens by various stakeholders. Like I think already been doing, like AIOS, All India Ophthalmic Society has been doing it throughout the month. They have a special program, and Vision India also has been doing it through its partner institutions. Like that, I think every stakeholder has been doing it to their own part of it through on various occasions. Like I mentioned, Wall Side Day, Diabetes Retina Month, Diabetes Month. So though I think those kind of these things will go on, but largely the public awareness is a crucial element. I would like to bring it once again. Therefore, the mega campaign and also around the clock and throughout the year is the one thing that we need to see. But at the same time, while we talk about raising the public awareness, we also have to be make sure that we are also the supply side, where we are raising the demand side, as I think initially that Vaishali pointed out. Who is going to do the screening? And so while we raise the demand from one side, who is going to make sure the supply bit? This is what, in fact, it applied this issue, demand versus supply issue, it happened in TB control program. There were a lot of mega campaign happened, and therefore a lot of referrals start coming to the district microscopic centers. But there's no facilities available to treat those cases. So there was a kind of imbalance happened. That imbalance was, of course, later on, rectified. But I think there's a lesson that we had from that kind of program. Therefore, we need to really keep that lesson in mind in the beginning stage itself. Look at the supply and demand both simultaneously and address the issue. And therefore, look at encourage people to have because I think the detection point of view, even optometrists actually can detect the DR aspects of it. So definitely ophthalmologists anyway there, and the optometrists also were equally qualified. They do kind of BSc optometry like that. So we have that population already ready. But I think more importantly, the latest recently published, the Gazette notification by the Government of India, which is about the National Allied Healthcare Bill, Allied Healthcare Bill, which came up on March 2021, which actually recognized, the ophthalmic assistants, vision technicians, and also the optometrists, also key force in the whole eye care sphere. So they also need to be trained on the detection of DR, and therefore we'll have a diploma holders, BSc optometry, and also PG and ophthalmologists all together. So that's kind of eye health workforce. So need to really increase the size of it, which is of course is growing up. But I think we need to really see that. Earlier there was a proposal that diploma courses would not be continued sometime as a few years ago. We actually addressed this issue, and we make sure that the diploma courses are continuing in the country. Therefore, we have growing eye health workforce, and therefore, and the combination of collaboration with different bodies. I think
Okay, so
collaboration,
the growth,
coordination, the eye health
yeah.
workforce are the keys.
Yeah, so I would like to go to Dr. Manoj. What do you think the retinologists and diabetologists are doing a lot of things in the constrained time, but what more to collaborate and to raise awareness?
Well,
Quick pointers, please.
I think one, let me congratulate this initiative with Economic Times that this kind of discussion is something which is going to help and facilitate more collaboration. There's already work in progress. The Indian Vitreoretinal Society that Dr. Vaishali is a part of, and the RSSDI, the Research Society for the Study of Diabetes in India, already have collaborated, and we came out with a joint consensus statement last year on trying to create more awareness on diabetic retinal eye disease. The aspect is that the medical community is doing its bit to make each other aware and create consensus and specialized statements and protocols. What we need to do is to take this aspect to uh, the population out there and the population in general and people living with diabetes to understand more about the prevalence and the possibility of this complication and the means to avoid it right from the beginning by keeping their blood sugars under control and taking care of all other aspects of the metabolic profile so that one does not land up with this complication. And of course, early screening so that if one is headed there, we are able to offer them a suitable treatment right where it should be needed.
Dr. Manoj, quick pointers from Dr. Rohit, and then I'll go to Dr. Vaishali. Dr. Rohit.
No. I think I just wanted to say we need to find innovative way of screening, because I think screening, if you tell to somebody come screening, it's very boring for them. Why we have to go there? There is no pleasure in that. And so unless they are affected, so you go to a shop, you buy something, you have something, there is some pleasure, but there is nothing you are getting in screening. You just go there, spend your time. So people also are very conscious. Why do I spend my time? They will just go and sit on mobile, but they will not come for your screening. So how do we find innovative ways to make them come and get screening done or create awareness? Probably a, a kind of message. How do we convey that message in a very innovative way? I think that should come out, because we have been talking this for almost like so many decades, and we have reached a certain stage. But I think if you want to go far, probably we need to think out of the box, more innovative ways to reach these people. And probably as a doctor community, we may not have much ideas, but we should go to public and ask them what would attract them, what would they want actually for diabetic patients and all. How should we do that? Because I'm
Okay.
sure people will have more ideas nowadays with the use of Instagram, YouTube, and all. People may come with so much of ideas that we have not even thought of actually.
Okay, technology will help. Dr. Vaishali, I know retinologists and diabetologists have been doing a lot of things, like quick pointers from your side.
No, I agree. And I agree, with Dr. Manoj that it's not only the RMP, which are the point of contact, there are also chemists, in many places, they just consult the chemist as doctors. And I think if we can place those cameras not only in the endocrinologist, but even in the chemist shop and get a free, Indians love free things, freebies. So if they are told not to spend, just to sit there and get a photo clicked, and for us, at one point, I was working with them on the automated camera, which doesn't even need to be manned. And I thought, like ATMs, we should have these cameras all over. So we are very far from there as yet, because even if we keep on detecting, what do we do with them? We had this issue. We started screening. We found 78% sensitivity in detecting, but they started referring all the patients to PGI, and it became a madhouse. We don't have a channel to support what to do after detection. So I think
Okay.
all these things will reach there someday.
Yeah. So I have few questions, but there are so many questions which are coming up from our audience. So I would like to take at least one or two. It will not be good if I'm not taking any of it. So let me combine one on technology, because a lot of people are asking us about AI-based diabetic retinopathy. Will it be in regular practice? Is there any new policies? I mean, I can put it like this. Do you think there should be technology aspect included in the newer policies? Dr. Fanindra, what is your take? But please have a few quick pointers from all the experts here, because we have already at 4 now. Yeah, please.
Sorry, I missed that, Pratibha. Could you
I'm
please repeat?
saying technology, how much of AI technology should be implemented in diabetic retinopathy? Newer policies, it should be adapted. How encouraging that would be? Because a lot of questions are coming on technology and AI.
I think Dr. Rohit, Dr. Manoj, Dr. Vaishali are the right ones to respond to that.
Okay, so let me go to Dr. Manoj. Dr. Manoj, over to you.
I think technology is making great headways in every aspect of medical field. And I did mention the use of AI for screening. In fact, one of the earliest uses of AI, at least in diabetes, has been in the field of screening for retinopathy. So already a lot of existing models, it makes it easier. On the basis of AI, AI is helping interpret these images without the need for a specialist there, so which allows early screening. So the same aspect that Dr. Vishali was speaking, if you have booths today in malls and railway stations, and if I'm able to just go there and get my fundus camera photograph done, and from through a validated AI get a report which tells me at least whether my retina is normal or should I go and see a retina specialist, will go a huge way in changing what we're trying to do here. So AI definitely helping. It's just that the right kind of validated tool should be used, which is where the government programs and government validation can come into place.
Okay, Dr. Rohit, your quick pointers.
It's just pointer is like along with technology is, I no doubt technology is playing a major role. Like now you have watches which can give your ECG and tell you what kind of abnormalities you are having and immediately send you to a doctor. So there are pointers coming up, and this technology is going to play a major role, and even robotic surgeries and all are coming up. So but along with technology, I think the role of physician is still there. So talent is already required to read these images and make interpretation, because patients should not feel that I have a watch and or I have something which had told me, so I have this problem. What is happening is now there is a doctor Google. People search on Google and go to a doctor and tell these are my symptoms. And so technology should be used along with the adequate talent. And the last thing is, which is tenderness, I think is very important, because these patients, when they come to you, probably you have to be very sympathetic with them. Technology won't do all that for you. Technology can take you to a certain extent, but beyond that, require talent and tenderness. Both is equally important.
Okay, so one of the last questions I would like to ask is about like looking at the future. What kind of newer therapies would be available right now? What is available, and how it's going to change the landscape to address the need of both DR and DME? And in the current scenario, from both patients and medical and scientific perspective, what is the biggest unmet need in the current treatment landscape for diabetes-related eye condition? First is that, and what your therapies are available, and how the future is going to transcend. I would like to go to Dr. Vaishali on this. Ma'am, quick pointers.
The future is not going to be newer therapies. The future is going to be into preventions. So you have to educate regarding lifestyle modifications, the newer branch of epigenetics, salutogenesis, how to prevent diabetes, because it's a lifestyle disease. So it can be prevented. I would not be looking at the newer injections and newer things to keep on injecting. I would rather be looking at finding the solutions to the root cause.
Thank you, ma'am. Dr. Rohit?
No, I think I agree with Dr. Vaishali, is that more of prevention, awareness creation and prevention is equally, because it doesn't cost you much, and it can go like regular exercises for these people, regular walking, 30 minutes exercise daily, a good walk for them. Probably that is something which we should encourage them. Eating green leafy vegetables, diet is playing a major role. Like if you don't eat food, otherwise, what the quote is like, if you don't eat food as a medicine, you have to eat medicine as food. So probably, I think your food is very important. What kind of food you are eating, what kind of diet you are taking, what kind of lifestyle you are practicing. These are all lifestyle diseases. And not only this, like many other conditions are lifestyle. Probably the entire health is lifestyle. Now they're talking about food as a medicine. There is a new terminology coming as food as health. because if you eat good food and you take good of your mental health, physical health, diseases, or you will have genetic treatment for many of these conditions, but probably genes modification is something which is not in our control. But still, on next by 2050, by end of this decade, we'll have some gene therapies and gene modifications treatment coming up also.
Yeah. Okay, so now we've got the doctor's perspective, and they have also, like Dr. Rohit and Dr. Vaishali have specifically spoken on focus on prevention and detection. Dr. Manoj and Dr. Fanandra, first coming to Dr. Manoj, any key message that you would like to leave with the audience regarding the urgent need for prioritizing retinal health and diabetes management?
Well, my message is, let's remember that screening for retina, right at diagnosis for every individual with type 2 diabetes, and for those even landing up with pregnancy and diabetes, is extremely important. Let's be aware of that, not shy away from getting the retina screened. And this should be done then on an annual basis. Maybe it would be good for the population or patients with diabetes themselves to ask this question to their doctors and prompt them to get their retina screened.
Dr. Fanandra, your key messages.
Yeah, I agree with Rohit, absolutely. The lifestyle is, I think, a key. Any healthcare issue is about lifestyle. Just maintain a good lifestyle and be happy. That's my message at the end of the day.
Yeah, at the end of the day, everyone has to be happy. So thanks a lot to all the 4 experts here who had joined us for today's discussion. And the viewers who had been actively participating, they have been sending us a lot of questions there. And our experts here had been like responding as they were talking to me and responding to my questions as well. If there are certain questions which are not answered, we will definitely get back to you with the answers by the experts. So to wrap up, I would say with over 1 billion people affected globally, vision loss is a growing burden. We all know that, and many cases are preventable. And for diabetics, the risk of retinal damage leading to blindness is high, and we all know that. So today we have focused on raising awareness of diabetic retinopathy and diabetic macular edema. So let's work together to spread awareness, reduce blindness, and help make this vision light shine brighter for all. Thanks a lot to all the experts and to the viewers. And ET Health World will come back with more such sessions info with value packed and which has high on awareness on health and health space. Thanks a lot. Thank you. Thank you for joining us.
Thank you.